what a wonderful day has been so far with great presentations. And looking at the slide just tell us how wonderful Iraq is with all these nice places to remember. Dr. Ali Al-Fayyad kindly did that for us. And he was obviously not biased. He put all the major places in middle and south of Iraq, and he forgot the north. So I'm doing the next conference one.
There's no north. North of Iraq.
Well, because Dr. Ali Al-Fayyad did that, so we will do that, you and me, next time.
Next time,
exactly.
all the
exactly.
region.
All the beautiful places in north of Iraq, we will put it on the slide next time.
Sure.
So that will take us to our third session for today. It's preventable medicine. And it is my great honor to introduce Dr. Nian Rashid, who is our moderator for the third session. Dr. Nian is a consultant senior staff specialist for obstetric and gynecology at the Nepean Hospital in Sydney. She has finished her fellowship of obstetric and gynecology in 2010, and she's been working in Sydney since then. Thank you so much, Dr. Nian. Please welcome.
Thanks for presenting. Good afternoon, everyone. Thanks for inviting me. Thanks for the committee and the hard work they have put into this conference. It's fantastic. Now, our next session is the preventable medicine, and our first presenter would have been Dr. Muhammad Al-Ansari, but unfortunately his flight from Melbourne has been cancelled, and Dr. Ahmed Al-Rubai will do his presentation. But I'll present Dr. Muhammad Al-Ansari. Dr. Muhammad is commenced working in Australia in 2012. He underwent his physician and gastroenterology training in New Zealand at Auckland Clinical Training Network in Waikato Hospital, and Otago Teaching Hospital, London. Dr. Al-Ansari then worked in Middlemore Hospital in Auckland, New Zealand, where he underwent a research fellow position in endoscopy, during which he completed research project in capsule endoscopy and colon imaging. He received an award for the best research twice by the New Zealand Society of Gastroenterologists. He has been on the board range of interest in all aspects of gastroenterology, including inflammatory bowel disease, GORD, GI bleeding, and capsule study. Now we've got the update on the bowel cancer, which will be presented by Dr. Ahmed. Thank you.
Thank you very much. Now, part of the deal to do this presentation, Mr. Ahmed, is they add 1.5 minutes. So there'll be extra 1 minute, because I'm not familiar with the slides. This is the first time I see the slide. Dr. Muhammad Al-Ansari, all flight canceled last night, and he was giving 4 o'clock to fly to here. By that time we finished. That's why he sent his apology. Now, you know, we're talking here about surveillance and screening at the same time. Probably we put it as screening more than surveillance, because surveillance is a gastro decision, right? But so I'll focus more on the screening. Now, everyone knows that colon cancer is one of the top 5 cancers, and in fact, the risk increased with age, to the extent 1 in 23 are affected by colonic cancer. I'm not very familiar with this slide. So now, the idea for the screening in colonic cancer came in from the fact that cancer arises from adenomatous changes, from an early lesion, which develop starting with a very small size and with a very benign type with no dysplastic changes. Now, we have two main polyps, or types of polyps, with the different pathways. One is the adenomatous polyps, which are the tubular, villus, and villus. In this sequence, the faster to grow is the villus. And we have the serrated adenomatous polyps. And the pathway in terms of the genetics and in terms of the rate of developing dysplasia, then cancer, is much more with the serrated. So it's estimated that 7 to 10 years are required for an adenomatous polyp to develop into cancer, while for the serrated adenoma, the sessile serrated adenoma, as I say, it is anything around 5 years. And that's why the surveillance is different. Now, the fact that we're having those picked up early means an early detection of cancer. And all statistics support the fact that the survival is much better with the early detection. And from this, the National Bowel Cancer Screening Program as a project appeared in 2006. So this is the impact on survival. You can see it's a significant difference. Now, the National Bowel Cancer Screening Program started in 2006, and I remember very well the age cap was between 55 and 65 years, and it was trial. 3 years down the track with the study of the evidence, that was extended to include in 2015 to age between 50 and 74. And it's based on sending a kit to do the samples every 2 years from the age of 50 to the age of 74. There's no evidence that after 74, screening would add any benefit. Now, over the last 30 years, there was a trend to have more malignant lesions in the colon among young people. Young people means less than 50, right? And the increase was significant. You can see in terms of the percentage, in terms of the number of cases, it increased from 8% to 13%. That is among young people. And the mortality is higher. The reason why is, first of all, there's not much awareness that all of us think that cancer means old age. That's one. Two, symptoms arise in cases of cancer, usually explained on other bases, because it's probably unlikely to have a 25-year-old guy with a cancer when he has, for example, pain or when he has anemia, right? So for this reason, we have a lot of higher mortality with the young people. Now, in 2024, the target in the National Bowel Cancer Screening Program changed to include all ages from 45 to 74. That is the program, National Bowel Cancer Screening Program. But it is also a recommendation to start the fecal occult blood testing from the age of 40 by the GP. So for the program itself, the screening starts at the age of 45. They send the kids every 2 years from the age of 45. But for the general surveillance, it's recommended that after the age of 40, the person goes to his GP to arrange for him to have second yearly fecal occult blood testing. And that's the major thing. Now, I'll come to this a bit later, but I just meant to see just one minute about why we have this rise in the cancer at a younger age. One of the most important causes is the increase in the prevalence of inflammatory bowel disease, Crohn's and ulcerative colitis. And we know that uncontrolled disease in Crohn's or ulcerative colitis is a risk factor for dysplastic changes which can change into cancer. So we have for sure more prevalence of this. So that is one of the factors for this. The second factor is, believe it or not, is the preservatives and polluted food with microparticles from plastics or air. So this is an established يقولوا لي 3 minutes انا ابقى الى انا خلص لان لان I haven't seen this. All right, so just to explain why this increase in that. While in the age of 50 there is a decline because of the program. Now the participation rate, believe it or not, although it is free, although the colonoscopy can be done if it's positive in a public hospital, the participation rate is low. It's never reached the target of 54 or so, 56. So that's the compliance with the test. يعني they arrive at home, but no one done it. So that's one of the problems there. And raising awareness, particularly among our community there and the migrant community. Now, colonoscopy participation, there was a stage where the need and demand for colonoscopy for the exchange was very high, and they couldn't cope with that. That's why the priority to do colonoscopy is now priority 1. So it is category A, which means the positive fecal occult blood test should be done within 30 days. That's why now the hospitals are committed for doing this as a priority over other indications. And that's why there is this improvement in the compliance with the colonoscopy. I'll pass through all this. What to use for screening? A fecal occult blood test is superior to the DNA testing of the stool and the blood. Now, what you do, if it's positive, you send for a colonoscopy. What about after the colonoscopy? If the colonoscopy is negative, then the next fecal occult blood testing should be 5 years down the track. But if the colonoscopy is positive, then this will depend on the finding, on the polyp formation. We have certain criteria for doing the surveillance, depending on the type, depending on the number, depending on the location of the polyp.
1 minute.
أتفهم بعدين نتفهم. Now, just one thing here is a doctor put CT colonography. CT colonography is not anymore a modality to use in screening or in diagnosis, simply because it's just a diagnosis there. And the specificity is limited. Which patient to screen? Now, we said the age, first of all. Secondly, when there is family history of colonic cancer, and when there is familial syndrome, and inflammatory bowel disease for the screening. Surveillance, it depends if there is a cancer before or not. Okay. I don't know whether you'll be interested in this. This will be maybe the last slide, Doctora. So generally speaking, if you have first-degree relatives with colonic cancer above the age of 55, this wouldn't add to the risk. That's why it's enough to do fecal occult blood testing, and there is no need to do a colonoscopy. So fecal occult blood testing by the thing. But if you have one first-degree relatives less than 50, or if you have one first-degree family member with 2 second-degree family members, then you have one of 2 options. Either you do the fecal occult blood testing from the age of 35, or you do colonoscopy 10 years younger than the index case. So, يعني, if the index case at the age of 50, for example, then all relatives should have colonoscopy at the age of 30. At that age. So it's 10 years younger than the index patient. Now, category 3, if you have 3 first-degree relatives diagnosed with cancer at any age, or you have 3 first-degree relatives and second-degree relatives with one of them under the age of 55, then it is definite colonoscopy 10 years before the age of the index. And that's why part of the implementation, that all family members of the index case should be checked and history taken, and she shouldn't be taken lightly. Now, we have these familial polyposis, we have different type of syndromes. Usually we start at the age of 10, sometimes 12. But in those with less severe expression, from the age of 18 to 20. In fact, one of the syndromes, we recommend resecting the colon very early at the second decade. Now, for inflammatory bowel disease, generally speaking, your patient, if the patient has a pancolitis, then after 8 years of the diagnosis, he should have the colonoscopy every 2 years. If it is just segmental colitis, then after 10 years of diagnosis, he should have every second year checking on the dysplastic changes which might appear. And this doesn't depend on the symptoms, by the way. So post-cancer resection, there's a colonoscopy 1 year after resection, if the resection is on the right side. But if the resection on the left side, probably the right side wasn't screened, that's why it should be within 6 months. So left-sided cancers, within 6 months, right-sided cancer, 12 months, and then another one in 3 years, and then every 5 years. I think I should stop here. This is very complicated screening. Let me see if you put, I think for chemo prevention, there is nothing established. So the aspirin, there is a soft evidence that using the aspirin delay the progress of dysplastic changes, but we don't use it routinely. Some NSAID also mentioned. Waqfat, Doctor, when she stands, she's very, very scary. Very scary. When she stands, very scary, yeah. Okay, just finish, Doctora. There is no evidence that screening or surveillance after the age of 75 will alter the mortality. I think that's all procedure for me. Thank you very much, and sorry for that.
4 minutes extra غرامة دكتور.
Thanks, Dr. Rubai. That was great. Presenting somebody else is always hard. This next speaker is Dr. Ahmed Samarai, reconstructive urological surgeon. Dr. Ahmed is an accomplished physician who had practiced urology in Australia for over a decade. After attending Baghdad University School of Medicine, Dr. Samarai began his focus on neurology, gaining a fellowship through Jordan University. Dr. Samarai then received further fellowship in Ireland, New Zealand, and Australia. He has been awarded accreditation from both European and Arab Board of Urology and published contributor in several medical journals.
هسه صار شغلتين على دكتور علي ترى. صار شغلتين، الشغله الاولى دكتور بالبوستر انت اي شيء من الشمال ما جايب لنا اي شيء، وعندنا الدكتوره كرديوها، بس الشغله الثانيه حول لنا الدكتور احمد الى فيزيشن. دكتور احمد one of the best urologists in Australia, and he is one of few urologists start to use robotic surgery in urology. So he's not a physician.
Thank you. I'll give you one secret about bowel cancer prevention for men. 25 milligram sildenafil Viagra daily is proven in vitro and in vivo studies to prevent bowel cancer. Right, this is a PSA screening. Thank you for having me. The PSA is a big topic. Prostate cancer is the second most common cancer in the world, only after skin cancer. The screening of prostate cancer has shifted in the last 12 months because of the pressure from the societies to prove no harm. So the recent shift has been against routine testing, and now it's risk-based and informed consent decision-making between the poor GPs who have no time, and they should initiate the subject and discuss with the patient the harm and benefits. But the good news is you don't have to do a DRE exam anymore. That's it. The DRE is out, so big clap for that one. Yeah. So you have the guidelines for the Royal College of GPs for the Red Book. I'll give you a very quick summary of a patient. So if he's average risk, that's 50 to 69 years of age. That's called average risk, no family history. This patient, you can discuss and say, look, you can have a PSA every 2 years now. Medicare pays for it. That's easier, right? Average risk, every 2 years, PSA. Say it, average risk, every 2 years, PSA. It can save lives, your loved ones. Higher risk. Higher risk has a family history of 2 members of the family, or he is African or Aboriginal. And those have a high risk, and those need to be given an annual PSA and be referred to the GP, to the urologist. Above 70 years of age is a different group, and for those we'll explain that you have to give them a decision-making about assessment individualized. So 70 years, healthy, fit, yep, he can have a PSA, but we don't recommend a PSA after 70 in most cases. However, we're living longer and healthier, so at 70 and above, you probably could give a patient that option. If a patient in the 4th group who has less than 7 years of expectancy, don't do a PSA. There's no benefit. Now to the first slide. So we now generated a peer-reviewed data on harm minimization. The government wants us not to do many biopsies because they're doing harm more than benefit. So they want us to reduce the harm. Therefore, this is the new guidelines. Cost-benefit analysis and application submitted. So we have the approval now for this application. The DRE guidance, GPs don't have to do a DRE anymore. That's good. Biopsy threshold, the pathway is very simple. If the GP does a PSA and the PSA is high, don't refer to us yet. Do it again in 2 months or 1 to 3. If it's again high, refer to us. What we'll do is we do the MRI. If you feel he should have the MRI through you, do it, but there's no rebate if you do the MRI request. If we do the MRI request, there's a rebate. I'm happy to get the patients to be just referred to me, and I can do a phone consult, bulk bill it, and do the RFA, do the MRI request for him on the phone. Because the MRI opens the second stage, which is the exact prostate size. Because if you look at this one here, there's a PSA density in the second paragraph. If he has a high PSA density, so the PSA is high for a small prostate, all China is in New Zealand, that's a high density, we have a problem. So if you have a high PSA in a small prostate, that's a high PSA density, you should refer him. So any density above 0.15 is a high density, and this is a very good word. Compare the PSA to the volume of the prostate, for a starter. And testing initiation, of course, you do the PSAs, do it twice if you're not sure, then refer to us. Now, the shift of follow-up is now restricted to these numbers. If you find that the patient has a low density on the MRI, or he has MRI of less than 3, there's 5 numbers in MRI. Pruritus 1, 2, 3, 4, 5. If he's MRI above or at 3, refer to us. You don't do more screening beyond 70 unless the patient is very healthy over 70 who has a rising PSA above 5.5. That's because we sedate and stop the screening because there's no evidence that above 70 years of age there will be any advantage of reducing mortality. In Australia, we moved to the number 40 to 45 because if he has a family history or a BRCA gene positive, that's a strong family history, we would recommend they come to see us before 45 or around 40 to 45. So we start screening for the high-risk younger guys if they have the BRCA gene positive or the family history. So again, the whole idea was to shift away from the old system, which is PSA for all patients, and refer to all doctors and do a biopsy early. Now we just have to do the PSA twice to initiate treatment. This is because the government is really twisting our arms really hard as urologists, saying do not do harm, because the past pathway was to do with transrectal biopsy. This is now almost obsolete. That's the last line. It's now standard to do a transperineal biopsy, which is why the infection risk went from 5-6% to 0.1%. The new guidelines are therefore tailored for the busy doctors. You can't do everything. Your time is limited. You have the PSA, do it twice, and then refer to us. The previous guidelines were very complicated, which is why we simplified them for your sake. And for us to reduce the cost on the government, we had to accept to have the PSA once every 2 years as opposed to once every year. That's a big saving on the budget for the Medicare. and to reduce harm. Yeah. We are yet to receive the currently advised NHRMC, and we're fighting to bring back some of the other details, but for now, as urologists, we have to accept. So strategy is very simplified. PSA is your initiation step. We have to see them if they have a density of more than 0.15 or a PRADIS 3 or higher. Yeah. Now, to be honest, in New Zealand and Australia, we have a better system than they do because we now have at least had 52,000 funded MRIs in Australia, which Australia can afford and the Kiwis can't. The guidelines focus now on having a detection of a CS, significant cancer. This is very important. So we try to find only those cancers that need to be treated. Because active surveillance for the sleeping latent cancers also costs money. You have to have a PSA every year. Yeah. Thank you. So the data are now shifting also to look at the high risk amongst the Aboriginal, Torres Strait, and also to the sub-Saharan Africans. They have a high risk by genetics. And this bracket, up to 69 age, remains relevant. We can make a difference if they have a high PSA. Government now funds the PSA every 2 years. Now, future roadmap is my roadmap. I'm doing it now already. I believe in the PHI test. It's a special blood test, saves you having to do the PSA and not know what the gray zone is. So the PHI is very handy, Prostate Health Index. It's a blood test sent to Brisbane. The PSA is in the PHI, as is the free ratio and the P2 protein. So if you think about a test after your first high PSA, do a PHI. And then you can allow an ultrasound of the rectal approach to get transperineal samples in the office, which is office-based transperineal sampling. We also have the high-resolution ultrasound in the office, which can pick up the changes early in the prostate. So we need to act faster than the cancer does. We emphasize on the importance of not doing harm because no other cancer defines rich and poor amongst countries like New Zealand, like cancer prostate. If you're poor, you get a transrectal biopsy. If you're poor, you get a no PSA. If you're poor, you get an open surgery. If you're poor, you get late diagnosis. Even among countries, if you diagnose the cancer in Egypt, there's no PET scan in Egypt. So when it comes to the PET CT, we now don't do a PET CT unless we really have to. That's the PSMA PET, which is no longer funded for pre-biopsy. Because you have that gray zone when you have a high PSA, negative biopsy, what do you do? Or a high PSA, but you don't want to do a biopsy yet, what do you do? So far we cannot justify doing an open path for PET scans. It's a very expensive study. Thank you. 1 minute left. I just say one thing. Sure. Yep. So DRE is out. PSA is your first test. If it's high, don't worry. Do it again in 1 or 2 months. If it's very high, refer. Don't worry. Just refer. And then the MRI happens quickly. We do the MRI and then we do the PSA every 2 years, and we expect to have more guidelines in the next 6 months. Okay. Thank you.
Great. Our next presenter is Dr. Haura Naqshbandi, consultant breast radiologist. Haura is a fellow of the Royal Australian and New Zealand College of Radiologists. Current role, she serves as a consultant breast radiologist with clinical ties to the Macquarie University Hospital in Sydney. Her expertise is focused on breast imaging, including completed breast imaging fellowship. Haura holds a membership of the Iraqi Australian Medical Association. The stage is yours, Haura.
Good afternoon, everyone, and it's a big privilege to be speaking amongst you today. Gonna start our speaking today about the Australia Breast Cancer Screening Program. We usually used to acknowledge the country and the land. I think it should be already done early in the morning. So for decades, Female breasts were known as the organs of beauty and femininity, and they used to keep poets busy. At some point, we have converted them into the organs of cancer, probably to keep our clinic busy and keep the business running. So breast cancer screening program in Australia is a big program, more than 30 years old, and it really helps to reduce the mortality and morbidity of breast cancer. The eligibility, I think most of you know, is female between 50 and 74 years old, and no referral needed. It is free, and they can offer all female staff, and you can do or send patient to the mammography breast screening regardless of breast density. One of the backsides of the breast cancer screening program, just like in any other thing in the world, is that it is one-size-fits-all program. And you know, you are physicians and you know all that it's hard to put one-size-fits-all program to people because, you know, people have different ethnicity, risk factors, there are different age groups and sex. So for the breast cancer, you know that there are two types of risk factors, the modifiable and the non-modifiable. I've put in the non-modifiable ones. Most of them we cannot change, like the gender, the age of the patient. But we have one non-modifiable risk factor, which is now everybody is speaking about, is the breast density. So mammographic breast density is a term used to the relative amount of dense breast tissue, the glandular tissue to the percentage of the glandular tissue to the fat. So this is an illustration of the breast density. How can I use the? Yeah, okay. So starting from here, this is the density A or birad A, which is mainly fat. This is the B, which we call the scattered, and then the C, which is the heterogeneously dense breast, and the D is the extremely dense breast. So the breast density is something that you cannot assess by examination, and you cannot determine it until you do the mammogram. So it's only definable by the mammograms. So why breast density is important, and why all the talk about breast density nowadays? Two main reasons. The first reason is, as I was saying, is that the breast density means an increase of the percentage of the glandular tissue to the fat tissue. Breast cancer usually happens in the glandular tissue. So it's simple. More glandular tissue, more risk of cancer. The other thing is that both the cancer and the dense glandular tissue appear white in mammogram. So let's have some practice here. And I will ask everybody, in picture A, the fatty density breast, can you find the cancer? Is it here, 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 or here? Yeah. So good. Everybody here could find the cancer. We will repeat that practice in picture B, the scattered breast density. Is the cancer here, 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 or here? The dot one, the whitish area. And if you move further for denser breast tissue, the breast cancer gets more difficult to find and more difficult to find. So for this breast, the breast density D, even very well-trained eyes, like radiologist eyes, breast radiologist eyes, cannot find. So we are now in a dilemma. I'm telling you that there are people with high risk of a breast cancer, and I am telling you to send them for me to do mammography, and I'm telling you that I cannot, or probably cannot see the cancer. This dilemma, we have in radiology, we have a lot of substitution and a lot of other ways to solve the problem, like ultrasound. Ultrasound, sometimes when the cancer is really hard to find by mammography, ultrasound is easier to find the cancer, especially in dense breast. The other modality is the tomosynthesis. I'm not sure if everybody is hearing about it. The tomosynthesis is multi-slice mammography. So instead of one picture, we got multiple slices of the breast, just like the same principle of the CT scan. And that will help us to see the cancer in more denser breast. And of course, the contrast enhanced mammography, where the cancer can, so we have something called subtraction. We reduce the signal from the glandular tissue, and only the enhancing cancers or enhancing lesions stay. And of course, the mammography, which the backside of the cost. The MRI, yes, is costly. Okay, so for the GP, I think this is the most important slide in my presentation for the general practitioner. This is your guideline how to manage patient according to their breast density. People with density A and B, I think they will be easy. You will depend upon the risk of them. And then density C, even if they are high-risk people, they need to be referred to the familiar cancer service clinics. BI-RAD density D, you have to discuss with them also and measure the risk and see where to refer the patient according to this Australian government guideline. How to measure the risk? These are two softwares that are defined by the Australian government, and you can use any of them. It's very simple. You can download that on your phone and measure the risk and go back to the to that list and decide the way of the management. So the breast screen program for cancer screening is still also, the compliance is only 53%. And it is a shared responsibility for all of us. Everyone working in the middle field, you have to, I think we need to think again, have we done enough to help people to go and involve in the screening program, or can we do more, and what can we do more? Yeah, and of course, breast screen is the first step in the patient's breast health, but unfortunately, it is not the last step for them. Breast cancer people need a lot of cooperation. They need help from all of us, psychologists, psychiatrists, gynecologists, and they will pass through a lot, and they will need the support of all of us. I thought I will put the BI-RAD slide, which is like we as breast radiologists cannot talk without saying anything about the BI-RAD. So just probably take a picture of it. It's the language that we use to describe breast lesions, and it is the common language that we use with the surgeons and the clinician to understand what is the next step, the best next step for patient management. And thank you. And I will be happy to take any more questions about breast imaging and interventions anytime. Thank you.
Thank you. Our next presenter is Dr. Media Elias, obstetrician and gynecologist. She's a fellow of the Royal College of Obstetrician and Gynecologist and is known for historic patient-focused approach to women's health. Dr. Elias consultant at multiple sites across Melbourne's northern and western suburb. Media provides comprehensive care for a wide range of women's health conditions, including obstetrics, antenatal and postnatal care, supporting expectant families through stages of pregnancy. She's a gynecologist and she offers advanced laparoscopic surgery, keyhole surgery. She manages menstrual disturbance and PCOS, pelvic pain, endometriosis, and pelvic organ prolapse, abnormal pap smears, and colposcopy. And she's managing menopause and HRT. The stage is yours, media.
Thank you very much, Dr. Nian. And my talk is about cervical cancer screening. As we've mentioned, the screening program is for us to detect and prevent cancer before it happens, and cervical cancer is one of the most important cancers when it comes into that. Why cervical cancer? Because it is the 14th most common cause of cancer for women and people with cervix in Australia. And at the moment, about over 946 cases has been diagnosed in 2025 in Australia. That is 1 in 190 cases, or about 0.5% by the age of 85. Or more than 70% of those women with a cervical cancer, they have not had screening, or they have been not screened regularly. And this is an ongoing battle. The role of the HPV virus or human papilloma virus in cervical cancer has a big, big impact, because 12 carcinogenic types to human have been found. And from those type, HPV 16 and 18 are considered to be the most oncogenic types, being responsible for more than 70% of cervical cancers worldwide. HPV is the common virus that affects the genital tract. More than 80% of people contract the virus at some stage of their life. So it's very, very, very common. And I usually start by saying that to the patient, because they all walk in with a HPV result positive, and they all feel like they have cancer. So that is not true. The other risk factors, as we know, is smoking, weakened immune system, and long-term use of oral contraceptive pills. And that is mainly not because of the pill effect, it's because of not using the barrier contraception method. Therefore, more exposure to HPV. So the objectives of today's talk will be to look at the current cervical cancer screening program in Australia and understand the new guidelines of 2025 updates, and clarify the role of the general practitioners in regard to screening and follow-up. And by doing that, hopefully we can improve patients' participation and detection. So if we look at the National Cervical Cancer Screening Program, that has replaced the old pap smear test since 2017. And HPV virus came into role as the primary test for detection. The target group is from the age of 25 to 74 years of age after the commencement of sexual intercourse. And the screening interval is every 5 years, which is very safe to do. Why cervical cancer screening test? Because it detects human papilloma virus, which is the cause of most cervical cancer, as mentioned earlier. It is more sensitive than cytology, and enable us to detect earlier intervention and support the goal of Australia, which is aiming to eliminate cervical cancer altogether by 2035. Anatomically, if we look at the cervix, this is the start of, or the entry to the uterus. More than 90% of cervical cancers, they start at the squamous cells at that junction, and about 10% are columnar type or glandular type. And the changes happens in that area in between, which is our squamous-columnar junction. Who is eligible for the cervical cancer screening? All women or people with cervix aged 25 to 74 who have had any type of sexual contact, and that is skin-to-skin, genital skin contact. Because the use of condoms, as mentioned, doesn't give us full protection, and there is not full coverage of the genital skin area. If the person is gay, lesbian, bisexual, transgender, or straight, they still require screening. If they have had HPV vaccination or not, because there is no full protection against all type of HPV viruses. And they are no longer sexually active. If they are postmenopausal, they have been with one sexual partner throughout their life, and we get that question a lot, they still need to have screening. And they have had children, or they are currently pregnant. Very, very important. Pregnancy is not a contraindication for HPV screening. Who is not eligible? The patient who display any symptom that might be as a result of changes in the cervix or cervical cancer, like unexplained postcoital bleeding, abnormal looking cervix on examination, and intramenstrual or persistent postcoital bleeding, postmenopausal bleeding, unexplained or persistent vaginal discharge, and post-treatment of adenocarcinoma in situ, and if the patient has been exposed to a DS in utero. So in this group of patients altogether, they still can have this test, but not as a screening. They will have it as one of our method of detection and diagnosis of their symptoms. What's new in 2025 update is the expansion of the self-collection access. Now the patient can have it in different forms, even if they have had treatment, and that replaced the test of cure pathway that we used to call it. The whole pathway is being simplified and have much simpler protocol to follow, and then we'll go through some of the changes to the management of abnormalities. The main key update, number one, is the self-collection test. Simple, easy, affordable, and the patient can have it within a few minutes with very minimal discomfort. And that's available now for all patients. It's a simple vaginal swab, patient collected, and it is, when we look at the accuracy, it's very comparable accuracy to clinician collected sample. It improves access and participation and really overcomes lots of barriers that patients might have. The role of the general practitioners, it's really to take that opportunistic approach and mention it to the patient when they present with any other form of symptoms not related to their screening test, and we can mention at the end, by the way, have you had an updated screening test? And we offer it as a routine test, and it's especially useful in under-screened non-English speaking patients. The second key update has been on the test of cure when the patient have had high-grade squamous intraepithelial lesion treatments. Used to be a complex cytology and HPV pathway, and they had to have two tests with negative on both cytology and HPV, but now it is simplified. They can only have annual HPV test, and it can be self-collected and require 2 consecutive negative test results. Then they can go back to routine 5-yearly screening. The third update is in the post-treatment surveillance of adenocarcinoma in situ. They used to have annual screening yearly indefinitely throughout their life. Now it is yearly screening for 3 years. If they are negative for the 3 years, then they can go to 3 yearly, and if they're negative for 5 years, then they can have that as their 3 yearly screening as an ongoing for the rest of their life. For patients with intermediate risk, where they have HPV non-16-18, now we have more conservative approach. It used to be 2 years and then refer to a colposcopy. Now we can actually have patient by patient and certification, and as long as they are under the age of 50, they're non-indigenous background, they don't have symptoms, and they have had their regular screening, then we can actually have more conservative approach and offer the third HPV testing. And that will delay the colposcopy and the discomfort from that. But it's very important to escalate from HPV testing before, as we can see, any changes in their cytology. And from that, the screening pathway is now simplified, so it's only HPV testing. If negative, return in 5 years' time. And if HPV is detected, there will be a reflex cytology on the result, and we base our management on the risk stratification. Special population, like Aboriginal and Torres Strait Islander patients, or under-screened or never-screened patient, or post-hysterectomy patient, immunocompromised, and pregnancy, they all have their special pathway, and that is by more frequent screening, which is usually every 1 to 3 years, and mostly every 3 years for those patients. The responsibility of our general practitioners is to identify these eligible patients, offer self-collection option as a routine, interpret the results correctly, and ensure follow-up and compliance. And really need to encourage participation. And as we know, most of our women come in, they do not want to participate because of embarrassment, cultural barriers, access issues, misunderstanding or lack of awareness, and self-collection, sample, and simple discussion really improves on all of these factors. So the key message is now that screening is every 5 years, very safe, which is what the patient gets scared of. HPV is very common and usually transient, so it can be cured. And early detection prevents cancer. Self-collection is easy and is effective. And the impact of the screening program really has a big impact on reducing the incidence of cervical cancer. Majority of cases, remember that, happens in under-screen or never-screen individuals. Thank you.
Could I please invite the 4 speakers for the last session for questions and answers?
Thank you. A very good presentation. A question to Dr. Ahmed. And unfortunately, due to the time limitation, we haven't covered the serrated adenoma management. So could you please just illustrate, or just very briefly, what is the recommendation in terms of the follow-up if we have, say, for example, a 12 millimeter SSA on the right colon and you discovered it? What is next step in terms of the message to our community?
Right. Now, knowing that the rate of progression to dysplastic lesion in serrated adenoma is much faster than the adenomatous polyps, then the surveillance is usually earlier. And right-sided serrated adenoma are more important. So when we do have a polyp more than 1 centimeter, 12 millimeters, I prefer to do it within 2 years' time. If we have small serrated adenoma, not 1 centimeter is actually critical measure there, even for adenomatous polyps there. We consider it as a big. Chances of developing is higher. So if there are multiple small serrated adenoma, say less than 5, then 5 years. 5 years and not 7 years. If there are, say, more than 5, then on both sides, left and right, then it is definitely 3 years.
Any more questions?
Sorry, can you hear me? Yeah. Yeah, so regarding screening, and maybe you can answer me slightly outside of the books and guidelines, given that we're all doctors. And do you see that there is a value in doing routine PSA if you're asymptomatic and above the age of 50? Or would you do MRI to yourself instead, if this was yourself?
I would do a PSA every year, and if it's above my age with a dot divide by 2, I would do a PHI and then MRI. Let me explain. If you're 55, it should be 2.75. If you're 60, it should be 3.0. If you're 70, it should be 3.5. So that's the true low PSA. PSA is inaccurate. It's only a red flag. So the PSA is your age with a dot divided by 2. In my book, I would do the PHI that same month. And if it's on the high risk to high tier medium risk, I would do the MRI. The MRI by itself can miss 17% of medium risk cancer and 8% of high risk cancer. So even the MRI is not perfect. The only perfect thing is the biopsy. Hence, if you're ahead of the curve at a game of chess, you want to do the biopsy first if you are in doubt, and use the ultrasound in the office with a high resolution transrectally to pick up the lesions of interest. So my pathway, cancers don't wait for Sunday holidays. So if you have a cancer, you should act fast. Hence, if you have a high PSA or a borderline PSA, PHI, move on to the MRI to help the doctor target the cancer area, which means he would minimize the number of biopsy samples taken. And because now we have a third curative treatment option beside radiation and beside surgical removal called focal therapy, irreversible electroporation, also called the knife of nano. And with this one, we can treat the cancer very much like a lumpectomy in a breast cancer. We don't have to remove the entire breast. We can just address the lump in the breast. And in the prostate, being so deep and so difficult to reach, we can put these 5 rods of electric needles around the prostate lesion and subject the prostate to 20 to 30 minutes electric pulses, forcing their pores to open, and therefore programmed cell death starts. The prostate cells will die if you tell them it's time to die, because you're opening their pores, forcing sodium to enter in high concentrations into the cells, and that by itself is the programmed cell death, apoptosis of other cells. Unlike other non-solid organs, cancer prostate, being a solid organ, can respond to these pores being opened forcefully with a high electric voltage. Remember, it's a high electric voltage with no thermal and no cryo effect. So you aren't freezing or damaging the protein structure. You're just sending a strong signal to the cells to be programmed to death.
Just a quick follow-up question. So if the PSA is elevated and your MRI was negative, would you still do template biopsy?
And targeted. Template and targeted by the ultrasound and the finger. If the finger feels a lump, that's a cognitive sampling. If the ultrasound shows, well, there's 5 things you can look at: smudgy areas, cauliflowers, starry skies, and hyperechoic changes with strange shadows in between the T and the P zone. If you find those, you're kind of biased to sample from these areas as well.
What do you do for anterior and apical lesions that are often missed?
I do anterior, extreme, and apical sampling too. So we have 20 areas in the prostate. So go apical left, apical right, apical anterior and posterior. Then mid-region has a posterior, lateral, and lateral. Then you have the base, which has the 4 regions as well, and you have an extreme anterior and a far posterior base. So you take many samples, and this is actually just blind because you haven't got a target. That's the problem. So that's why I really have the move to the PET scan next. Because if your biopsy is negative but the PSA is rising, the only thing left is a PET scan PSMA, which can pick up 96% of cancers in current PET scans, 98% in the Melbourne PET scans, also called quadra scans.
Any other questions?
I'm a GP from Melbourne. My question is to Dr. Hora. Thanks for the lecture. It's about using iPrevent as a tool for GP to help for the prevention or even referral to MRI. If you can elaborate on that, please.
Yeah, so I think in the slide that I showed, the difference in the management of the patient will largely depend upon the risk of the patient. So sometimes there are a lot of risk factor that the patient have, like family history, personal history, and that will change the way that you would refer the patient. For example, the screening program is starting from 50 years. While if you see a patient that you find that she has high risk, you can let her start and join the screening program earlier, or at least send her for non-screening mammogram and ultrasound. And you will also be able to change the type of the exam that you will request her. For example, if you're having a patient that has high risk or a dense breast, you know that the mammogram will not show anything, so you might ask for mammogram plus ultrasound or mammogram plus contrast mammogram. And if you still have doubt, you can, I think, I don't know, probably the GP will be hard to refer for MRI, but at least you will refer her for the breast cancer clinic, and then they might need the MRI. Yeah. So the iPrevent will assess the patient as low, high, or medium risk, and then according to that, and with the other risk factor, you can, according to the list, change the way of the management of the patient and choose that. Yeah, and even the screening program, even if it is starting from 50, women can start joining from 40 if they chose to, or if their GP chose to. So the screening program, at first, when it was designed, there was a weakness point, is that it has a disconnection with the GP clinics. I argued with them once about the role of GP clinics in the screening program. They said that at first there was no role. It was screening and then directly to the surgeons. But now, after the implementation and the focus that started about the breast density, they come back and ask for the help of the GPs, because they are telling the patient after they get the result of breast density with the results of the mammography, they are asking the patient to go back to the GP and discuss about their breast density results.
We have only one more question, and the quick one has to be a minute.
Hi, it's Lena, GP from Sydney. Question to Dr. Ahmed Al-Rubai. I recently had a 57-year-old lady who's never participated in bowel screening program. She's asymptomatic and has a family history of colonic polyps. What should be the next step? Ask to do FOBT or refer to colonoscopy?
Sorry, Doctora, you have family history of polyps, not
polyps, no cancer.
This wouldn't add to the risk. So family history, even for a first-degree relatives, unless part of familial polyposis syndrome, then it is not a risk factor. So it is fecal occult blood testing, depending on the age.
I see. Thanks.
Thank you.
Thank you
very much.
Pause this session for the next session. Thank you.
Thank you so much. Yes, yes. Can we go back a slide? So Dr. Ali must have heard me talking about the photos, and he put this picture for Dr. Nian. So we can see the traditional Kurdish clothes up there.